Good evening, everybody. On behalf of the Deanship of Postgraduate Education, King Saud bin Abdulaziz University for Health Sciences, Riyadh, we would like to welcome you all for this live event. Thank you for registering with us. Today, we'll have 4 presenters from the PICU in King Abdullah Specialized Children's Hospital, Ministry of National Guard Health Affairs, Riyadh. Dr. Yasir Ghazaz, Dr. Hamza Ali, Dr. Hala Al-Alam, and Dr. Ali Al-Shahri. Each expert will be presenting their sessions for 15 minutes each. When all the sessions are done, we will have some time for answering your questions. You're free to post your questions to the presenters during this live event. At the end of the session on the attendance link will be published to you, on which you will simply enter your code, complete a survey, and avail your certificates of attendance. Now, please allow me to welcome the first presenter, Dr. Yasir Ghazaz, who is the consultant in the PICU. Welcome, Dr. Yasir, on board. Have a great evening. Thank you.
Hello and good evening. Thank you, Deepa, for presenting me. And I would like to welcome the audience who are attending our talk today about preparedness and management for COVID-19 in the PICU. I would just like to make sure, do you see my slides? Deepa, yes. So I'm going to be talking about the epidemiology for COVID-19 in children, the clinical presentation of severe COVID-19 in children, the pathophysiology in relation to respiratory failure and multi-organ failure. So as we know, COVID-19 was actually first reported in late 2019, and after that it escalated rapidly to be declared a public health emergency of international concern in January and a pandemic in March by the WHO. And on the 2nd of March as well, we had the first case of COVID-19 in Saudi Arabia. When we'd like to look at the number of COVID-19 patients and pediatric patients worldwide, so COVID-19 so far, there's beyond 8,000 cases in comparison to what's reported for SARS-CoV-80 or MERS-CoV-31. And that's primarily due to the high infectious rate and the higher number of actually people infected with COVID worldwide. In Saudi Arabia, in relation to the latest information, so we are aware that there is around more than 40,000 infected patients of COVID-19. Actually, 8 of those has been reported to be of pediatrics. Yeah. In the next few slides, I'm going to share some epidemiological data about critically ill pediatric patients. Yes. So the first report comes from China, about 2,000 pediatric patients. 1/3 of those were laboratory confirmed cases. Only 13 were actually in the ICU, taking the rate of critically ill pediatric patients in this population to less than 2%. And if we look at the graph, we can notice that actually children below than 1 year of age, infants 1 year of age, have more severe COVID in comparison to other children. Another report came from the CDC in the USA. There was 2,500 pediatric patients. Again, the hospitalized information was available from 1/3 of those, 700 patients. 15 of those only were admitted in the ICU. 5 out of those were again less than 1 year of age with 3 mortalities. But actually the biggest information and the most useful information come from the virtual pediatric system, which is primarily a USA database that collects data from the ICUs worldwide. I will just hold for a second. Seems my slides are not getting through. Sorry for that. I'll try to get it on again.
Yeah.
Seems that's stuck at the first slide, right?
Yes. You can move your slides, Dr. Yasser. You're
Yeah.
okay.
No, it's not actually. I've been moving them, but it's not moving for others.
Okay, great. Fine. It's great now. It's great.
Okay. So as I was saying, the data primarily comes, the biggest data comes from this database, which is the Virtual Pediatric Systems, which has more than 150 ICUs that submit their data there. So they created a dashboard for COVID-19 pediatric patients. And so far, up to 2 days ago, there was around 270 pediatric patients admitted to the ICU. Out of those, we only have discharged 120. Sorry, I'm holding because it seems it's delayed to reach you. I don't think people are seeing the slides.
You're fine, Dr. Yasser, with slides and your camera.
Yeah, but it's not actually the movement that you see is the movement I did 2 minutes ago. So anyway, so there's 270 pediatric patients reported in this database. The available data is for 120 patients. Out of those, five mortalities. As you see, the most age group admitted to PIC with COVID-19 was the age group between 12 to 18 years of age. In terms of the admissions per day, it's static, and that's reflected in the number of all COVID patients in the USA. In terms of comorbidities for this population, so we can see that infants or children below 2 years of age, most of them who are in ICU, they don't have comorbidities. However, older children, 2 years and above, and 12 to 18 years of age, they have either a mild or moderate to severe comorbidity. In terms of the epidemiology and respiratory support that this population required, so patients who are 2 years of age and below, around 40 actually to 60% in the whole population requires mechanical ventilation. Just conventional mechanical ventilation. However, there are 3 patients in this discharge data that are on ECMO, and only few patients on high frequency, and even few patients on non-invasive or high flow nasal cannula. So in summary, the critical care cases for confirmed pediatric patients seems to be less than 2%. In terms, the healthy infants seems to be prevalent. Older patients who have COVID-19 usually are patients with comorbidities, and it seems that at least 50% of those patients admitted to ICU required mechanical ventilation support. So why do COVID-19 doesn't affect pediatrics as much as it does to adults? So as we know so far that COVID-19 is similar to the previous SARS-CoV, so the other coronavirus, in terms that it attaches itself to the same ACE2 receptors. And it seems that those receptors are immature and they don't function as much as adults in this pediatric population. In terms of the presentation, so the presentation of severe COVID, so far COVID presented itself as respiratory, main in the ICU, more of lower respiratory and ARDS. It has other presentation of unusual abdominal symptoms or a multi-system inflammatory syndrome, which what we've been hearing about recently in the past 2 weeks, I'd say, in terms of Kawasaki-like or a toxic shock syndrome or a macrophage activating syndromes. In terms of the respiratory failure, so far, most of the pediatric presentation, as far as we know, they come with either bronchiolitis picture or ARDS. However, in the adult, there has been this theory of 2 phenotypes, which comes from Gattinini and the group in Italy. Basically, they define them as 2 phenotypes, the common or the phenotype that's known to us, which is the ARDS, which is pulmonary edema and inflammation in the lungs itself. The other type, which is the type L, is basically again, severe hypoxemia or respiratory failure with hypoxia, but the issue is not that the lung has severe pulmonary edema like ARDS. What they theorize is that there is loss of hypoxic vasoconstriction. So normally in parts of the lung that has pulmonary edema or has pneumonia, for example, they're going to be vasoconstriction. So the blood supply to those parts of the lung is going to decrease to prevent hypoxemia. However, they theorize that this normal physiological reaction of vasoconstriction doesn't occur, and that's going to lead to VQ mismatch and hypoxemia. So what they theorize is there's two phenotypes. However, as I said, in pediatric cases, what we've seen in reported imaging and CT studies, that they have two presentations. One of them is the classical ground glass appearance. The other one is the halo sign, which is again a ground glass area surrounding a nodule or a mass. In terms, I think, of the most interesting part of all of us is this multi-system inflammatory syndrome. So it initially was reported as a case report coming from China as a child with the Kawasaki disease. And the end of April, there was increase in the emerging cases of inflammatory syndrome that caused the British Pediatric Allergy to initiate a warning, and they wanted people to collect data. And the UK, again, Royal College of Pediatric and Child Health actually had a case definition for it to collect more data, and then we started seeing more numbers. So this is the first case report of a 6-month-old girl who actually had all features of Kawasaki except for lymphadenopathy. And she had a brother who 2 weeks or 3 weeks before had respiratory symptoms, and actually the family itself tested positive and they were isolated for COVID-19. Her lab showed elevated inflammatory markers in terms of CRP and ESR. She had a normal echocardiogram and her PCR was positive for COVID-19. She received the usual Kawasaki treatment. Later, as I said, there was the case definition, which is basically a patient who presents with fever, with signs of inflammation, with either a single or multi-organ dysfunction. And it has to exclude other causes, microbiological causes, and the PCR for COVID-19 might be positive or negative. And this is a summary of what I was able to gather from reported cases from UK, USA, and France, and it's basically a network and databases. So the UK, they have 37 patients of all age groups. All of them had fever, 3/4 had shock, and they had more GI symptoms in comparison to respiratory symptoms. Saying that, only 1/3 had a positive PCR and another 1/3 had a positive serology. So only 2/3 we had evidence of COVID-19. The lab was remarkable for markedly elevated ferritin, CRP, troponin, and BMP and D-dimer. Echo was done in 19 of those patients. 8 of them had severe dysfunction, so more evidence of severe dysfunction in comparison to delayed coronaries, which what we see with classical Kawasaki. Again, 70% required inotropic support, and the same number required respiratory support with 1 reported mortality. In USA, the cases that they report 15 cases, and those cases are between 2 to 15 years of age. Again, persistent fever, more GI symptoms in comparison to respiratory. Serology here was more prevalent. So 2/3 had positive serology and only 1/3 was positive for PCR with elevated inflammatory markers. More than 50% we know required inotropic support and 1/3 required respiratory support. France had the most of the cases, which is 51 cases. All ages, but what was remarkable there that more than 70% were 5 years and older. Again, the same symptomatology. They present either with positive PCR or serology in 60%. Troponin was mildly only elevated. However, BMP was very highly elevated, interleukin-6 as well, and echo showed the dysfunction. 80% required inotropic support, and they had 10 patients actually required via ECMO, and so far no mortalities. So in summary, this kind of a typical presentation presents in all age groups, maybe more than 5 years of age. They all have fever, inflammatory disease, more GI symptoms than respiratory, marked inflammatory markers, cardiac enzymes, primarily BMP, not troponin, with elevated coagulation and D-dimer, and echo might show dysfunction or abnormal coronaries. So the pathophysiology behind the whole kind of a respiratory and multi-organ dysfunction comes from what we believed, what actually was started by adult authors coming from China, adult cases. So they reported 150 confirmed COVID-19 who died actually, and what's remarkable on those was elevated ferritin, interleukin-6, and the dimer, suggesting that this mortality is high due to poor virus control, so high virus titer, and a strong body inflammatory response. So what we believe is that COVID-19 and those patients who died was associated with poor virus control, so it allowed the virus to replicate, and the anticoagulation and the anti-inflammatory pro-inflammatory balanced actually doesn't work. So we don't have this good balance, so we have more pro-inflammatory process that's ultimately going to lead to inflammation and cytokine storm. So usually with any new virus, that way that our body fights it is with innate immunity, and it's the first line of defense against those viral infections. And what has been theorized that there's a delayed release of interferons, one of the first steps that the body fights those infections. And with this delayed release, the virus is going to replicate even more. Ultimately, there's going to be release of interferons that are going to attract macrophages, and macrophages is going to have this huge pro-inflammatory surge. So cytokines, primarily tumor necrosis factor, interleukin 6 and interleukin 1. In turn, those inflammatory cytokines, what they're going to do, they're going to attract inflammatory cells, for example, into the lung, result in excessive infiltration and ARDS, and as well as going to cause apoptosis of the tissue, either in the lungs or other organs. In addition of apoptosis to T cells, so hindering the viral clearance even worse. And ultimately, the cytokine storm. This is actually sums and concludes my presentation. I would like to invite next Dr. Hamza Ali, who's going to talk about the clinical management of COVID-19 and critical children. Dr. Hamza Ali is a PICU consultant in King Abdullah Special Children's Hospital. Thank you, Doctor. Thank you all, and let's welcome Dr. Hamza.
Assalamu alaikum. I hope you can see my slides. Thank you, Dr. Yasser. My name is Dr. Hamza. I'll be talking about the part of clinical management for children infected with COVID-19, actually, especially in critically ill child. My outlines will be talking about the respiratory support, either non-invasive or mechanical ventilation, acute respiratory distress syndrome. Then we will talk about fluid management and briefly about the antimicrobial recommendations. You need to know that actually there is no pediatric data regarding treating pediatric patients who are infected in COVID-19. It's all epidemiological data presented by Dr. Yasser. And that's why all experts actually recommending adherence to the known recommendations to treat pediatric respiratory failure, ARDS, and fluid management, which is the most famous one, PALIC, and Pediatric Mechanical Ventilation Consensus Conference. And it's very important also to have your local institutional guidelines that will direct you through this uncertain management of uncertain disease. So we'll talk about assessing severity of the respiratory disease. Of course, when the patient comes to the PICU, he will be in acute condition, hypoxic respiratory failure. So you depend on your assessment as usual as any other critically ill child. In this regard, for example, increased work of breathing, which is the clinical assessment requiring oxygen to keep saturation within the normal range. That is, of course, the severe presentation of the COVID-19. And doing a blood gas to assess the gas exchange function. And this is, of course, very important, but in patients who are in respiratory failure and who are in need, of course, you might use also respiratory indices like oxygen saturation index, oxygenation index, mainly in the severe disease which requires respiratory support, non-invasive and mechanical ventilation to stratify the severity, and hence that will direct your management. This is a slide actually just will show you which patients might be at risk for ARDS. They are not in ARDS, but they are at risk for ARDS. Those patients who requires oxygen to keep their oxygenation within normal range, mainly above 88%, or if they are intubated, they need oxygen supplementation to maintain saturation above 88%, but the oxygen index or oxygen saturation index is still below the limit of the definition of ARDS. We call this at risk for ARDS, and they might develop an ARDS later on. So they need really quite close monitoring and observation. Assessing the severity of the ARDS is very important when the patient develops an ARDS. Beside, of course, the acute presentation, there's no cardiac involvement, explains the chest X-ray finding and the respiratory failure. We need to have this, respiratory indices. If the patient's on CPAP of more than 5, then with CPAP more than 5, the PF ratio less than 300, and saturation ratio less than 264, and there is no severity stratification if the patient on non-invasive. But if the patient is intubated on invasive mechanical ventilation, it is stratified to mild, moderate, and severe ARDS, and that's very important because maybe the management is different, and maybe in the severe portion you need to add some management is not required in the other portions. What about the non-invasive? So your patients admitted to PICU in acute respiratory failure, and you think non-invasive, it might work before intubating this child and committed him to invasive mechanical ventilation. You need to know that non-invasive ventilation is an aerosol generating procedure. It's very risky. You need to try to minimize the leak, and you need to use a proper bacterial filter on the mask or whatever interfacing you are using. And it's very important actually to close monitoring the patients and don't delay the intubation. If the patient didn't show any improvement, like work of breathing is worsening, oxygenation is not achieving your target, don't delay the intubation. That will just increase the risk of spreading the aerosols without benefit to the child. Same principle for high flow nasal cannula. Again, it's aerosol generating procedure, it's risky, and it's mandatory to monitor your child closely and escalate the management within 30 to 60 minutes to like non-invasive or even intubation mechanical ventilation without a delay. So what about, shall I start with high flow nasal cannula or non-invasive support CPAP or BiPAP? Actually, a recent adult study, I'm mentioning this because in the adult survive sepsis campaign, recent guideline, they actually prefer the high flow nasal cannula over the non-invasive ventilation because a low quality evidence and recent published study in 2018. But in pediatric, still we are considering the standard of care is the non-invasive CPAP and BiPAP, and just do your usual strategy for supporting a child with respiratory failure, maybe non-invasive and high flow nasal cannula in the situation that we are using usually, and there is no changes. What about the intubation? If the patient required intubation, again, intubation is an aerosol generating procedure, shouldn't be delayed, and it should be done by an expert in airway management, full PPE, negative pressure room, and you try to limit bag mask ventilation because bag mask ventilation, again, is an aerosol generating procedure. If you have to do it, you do it with two-hand technique to make a good seal and prevent leak and generating an aerosols. You try to provide the smaller tidal volume that you can with beep valve and bacterial vital filter, of course. Rapid sequence intubation is recommended because it's a fast methodology to intubate the child, and you might avoid the bag mask ventilation hence. And here on the right of the screen, you can see the sequence of rapid sequence intubation. It should be available for you. Actually, it should be directed for you, and that will help you to fasten the procedure. Of course, video laryngoscope is, if available, you can use it. And whenever you intubate the child, it's preferred to be cuff to tube, as we said, and inflate the cuff immediately to prevent any leak or aerosol generation. After intubation, what is the initial settings recommended? As usual, like tidal volume 5 to 7 ml per kg to maintain saturation between 92 to 96, 97%, and keep plateau pressure below 28. Some guidelines says 30, but it's like no major difference to avoid barotrauma. In regards of beep titration, the best actually evidence in beep titration is the Ards network protocol, which is taking in consideration beep and FiO2 grid. For example, if the FiO2 below 40, maybe beep of 5, when you find yourself escalating the FiO2, you have to escalate the beep, and this is the best approach for titrating beep to decrease the mortality in ARDS. Higher FiO2, you need to go with higher beep according to the Ards net protocol. Ards net management targets of the ARDS management, it depends on the severity. For example, mild to moderate ARDS, the recommendation to maintain saturation normal within 92 to 97. Whenever it is severe, you can accept some sort of hypoxia, permissive hypoxia, 88 and above. Permissive hypercapnia and protective lung strategy also is recommended. pH 7.15 may be acceptable. Plateau pressure should be maintained below 28 to avoid barotrauma. Tidal volume 5 to 8 in mild to moderate ARDS. It might be lowered in the severe ARDS again to avoid the barotrauma and further acute lung injury. Sedation, adequate sedation, proper sedation for mild to moderate ARDS. You need to deeply sedate your child to control the breathing if you are in the severe spectrum. What about the neuromuscular blocking agents? Again, it is the same actually in general in ARDS management recommendations. If mild to moderate or low moderate ARDS, maybe it's not needed. In severe ARDS, maybe it's needed within the first 24 to 48 hours. And boluses first. If the patient wasn't controlled by the boluses, you might go to infusion of neuromuscular blocking agents. It should be discontinued whenever the child starts to improve. Here, actually, they mentioned in the Pediatric Mechanical Ventilation Consensus Conference recently in this COVID crisis, they mentioned these parameters that PaO2 on FiO2 more than 150, oxygenation index below 12 and oxygen saturation index below 10. I mean, when the patient, it seems when patient is shifting from the severe to moderate ARDS, you can discontinue the neuromuscular blocking agents unless it's needed. The prone position, a lot of talk about the prone positioning in adult. It might help. Also in pediatric, it can be tried for 12 to 16 hours, and it might be considered early in the disease course because it might have some beneficial on the oxygenation. In the case of refractory hypoxemia of the ARDS, other adjunct management, it can be added like inhaled nitric oxide trial. It should be discontinued if there is no benefit. Actually, you can try it, but if there's no benefit, you should stop it. High frequency oscillator ventilation is still, again, as usual, as a rescue therapy. It can be used as in the case of refractory hypoxemia, but of course you need to pay attention to the prevention, protection of the staff by adding bacterial filter, minimize disconnection and open suctioning when the patient on high frequency oscillator ventilation, and at the last resource, maybe ECMO if your center actually is well equipped, experienced in the extracorporeal membranous oxygenation at the last resource for refractory hypoxemia and ARDS. What about the corticosteroids? We know actually it's not recommended, the corticosteroids in the ARDS, even in the severe ARDS. Of course, there's no data in pediatric, limited data in adults. Surviving Sepsis Campaign, WHO and CDC against the routine use of corticosteroid. However, it can be considered for severe ARDS. It's still weak recommendation. This is an adult. What about pediatric? Recently, actually, the Pediatric Mechanical Ventilation Consensus Conference, which is the respiratory part of the European Society of Pediatric and Neonatal Intensive Care in March 2020, they stated that based on recent findings from an adult study, use of systematic steroid may be considered to limit the pro-inflammatory state, especially in severe ARDS. So if the patient is in severe ARDS and you think or you prove that he's in a hyper-inflammatory state, you might use the corticosteroid. And for me, actually, I suggest before using the corticosteroid in such disease, in such no evidence situation, to be discussed with other colleagues from ID and maybe rheumatology before committing a child to a treatment. It might be harmful for him. For the fluid management, of course, it's a strong recommendation to follow the restrictive fluid strategy. Volume overload is well known, it's increasing the mortality. 75%, 80%, up to 90%, it depends on your experience, it depends on your evidence, it depends on your local institutional guidelines, but you need to pay attention to the intravascular volume. You need to strictly monitor input and output, and you need to avoid the intravascular depletion dehydration because that might lead to end organ hypoperfusion, acute kidney injury, and that might increase the mortality on top of the ARDS mortality. As Dr. Yasser mentioned, that in the adult, actually, they theorized two different types from the pathology of the ARDS, and that might differ actually the management. Again, this is adult, but I think this piece of information is worthy to mention even in pediatric if you notice it. There is the first type, which is the normal compliance type. They will be hypoxemic, but they will not respond to the high beep, and they will not respond to the traditional management of the ARDS. Maybe they will respond to high oxygen supplement. Inhaled nitric oxide, it might be beneficial in this stage because they theorize that the reason behind this is the lack of hypoxic vasoconstriction response. Maybe inhaled nitric oxide will help in this part. And high PEEP, it might not be beneficial in improving oxygenation. On the other hand, it might have a profound hemodynamic instability because the lung is filled with the normal compliance and low recruitability state. When they pass to the low compliance type, which is the traditional type of ARDS, then you use the traditional management of the ARDS, which is high PEEP, prone positioning, and as usual in severe ARDS. Again, this is an observation from the adult and nothing in pediatric. About the antimicrobial therapy, I think our colleagues in the ID that will give you a detailed webinar after a few days in this regards, but I think it's worth mentioning. CDC, Infectious Disease Society of America guidelines, Surviving Sepsis campaign, they were talking about hydroxychloroquine, chloroquine, lopinavir, ritonavir, and in combination with interferon data. There is no data at all to recommend with or against using all of this, actually. There is no evidence to recommend any of these antiviral or antimicrobial recommendation. Even the remdesivir, actually, which is FDA issued an emergency use authorization recently, and they stated maybe it can be used in the severe disease of ARDS, children and adults, but again, efficacy and safety is not guaranteed for such medications. So it's very important to have your institutional guidelines, agreed on recommendation to use it and utilize it in patients with severe ARDS before you commit your patient to such improved medication without an evidence. Using antibiotics, antibacterial, of course, is as usual. You can use it when indication. Thank you very much. Here I'm concluding my lecture and giving the mic to my colleague, Dr. Hala Al-Alim, to continue talking about other aspects of clinical management for COVID-19 in critically ill children. Dr. Hala.
Yes. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for asking me to join this webinar. And I'm just trying to share the slide. Are we okay? So as you can see, I titled my lecture as a COVID-19 and organ injured in PICU. As mentioned by my colleagues, that every organ is affected by this virus. And the most important thing is what our country is doing, the lockdown. So we stay home and we will work to flatten this curve. So outline of my lecture will be a disclaimer and reminder, obligation, and just a statement for our children and also for our organs. Recent event and what is labeled as novel in adult, is it really novel in children? And we will conclude and I will give you some advice and recommendation. So the disclaimer, nothing to disclose from my side, and a reminder, a child is not a small adult, and severe COVID-19 cases are infrequent in pediatric, as well mentioned by my colleagues. And no evidence does not mean absence of evidence. So we usually go and see the previous evidence, even with the similar viruses, and then we decide how to treat our patient. I have to confess that we pediatric intensivists are not the expert in the pandemic, nor in this pandemic, or nor in previous outbreak. When I reviewed the previous history evidence about MERS-CoV in children and in PICU, I found only a case report or a case series. Apparently, this virus is mild or moderate in children and rarely severe in children. So this is why our experience with such pandemic in pediatric era is minimal. So how certain are we about any science in this pandemic? I'm sure we are uncertain about the method of screening, method of diagnosis, course of the illness, option of the therapy, and the outcome. We see different screening tools from time to time, and also the sensitivity and the specificity of PCR. Sometimes we have a false negative, which can be a problem, and the course of illness is very variable. You cannot swear that this is COVID from the clinical presentation or non-COVID from a clinical presentation. Options of therapy, as mentioned by Dr. Hamza, that is very questionable. And again, it's in the adult era, and it's under big question in the adult era. Outcome, majority of our children are in good health, but we have some deaths. So that's the uncertainty we live in this pandemic. We are certain about something else, which is the social distance that can help, staying at home, hygiene at all levels, and observing the affected children, what is their course and what is their outcome. Again, all this certainty or uncertainty has to do with the phase of the pandemic. Alhamdulillah, we are in phase 1 in the kingdom. Others are in phase 2 or phase 3, especially adult. So what we learn from living with uncertainty that we need to learn, have more experience, and grow opportunity. What obligation do we have as a pediatric intensivist, as pediatrician, as every healthcare provider work with the children? We have to provide the standard of care for sick children. What is the standard of care? Does the standard of care change with it changing the circumstances? Yes, sometimes yes. We have an obligation to give the best available management. Even the non-available management could be jeopardized nowadays. We must document the rationale behind choosing certain management during the pandemic. Because a scientific opinion could be the evidence this time, scientific opinion, not an even expert opinion. We need to stay safe to continue serving the young population. So what to say to our dear children? We need to give them a safe environment at home. We need not to scare them, and we need to even protect them from the online activities, as it's more dangerous on them than COVID. So what the organs of the body, I ask myself a question: does SARS-CoV-2 virus spare any organ? Apparently not. As you learned from my colleagues, it affects every organ. Respiratory system, it's like in the previous talk, what Dr. Hamza mentioned in detail. I will not review it here. And then cardiovascular, again, Dr. Yasser Gazzaz did mention how the heart got affected, either directly or indirectly. Other organs, yes, every organ has an injury from this virus, whether the kidneys, liver, intestine, brain, skin, and eyes. Once you see a multi-organ involvement, you need to think about the cytokine storm syndrome, which has, again, different features. It's not fixed presentation. It affects many bodies. You can see here the heart. Heart can be affected directly, indirectly. Some of the children presented with Kawasaki syndrome, shock syndrome, Kawasaki disease shock syndrome, and with all the features, with some of the features, with coronary, without coronary, with LV dysfunction. So it's very variable. And again, we used to know Kawasaki as a pediatrician and pediatric intensivist. It's in early year, but apparently this virus can show it in an older age, which is preschool or even adolescent. Does it affect the kidney? Yes. Is it direct or secondary to the cardiac involvement? Still, we don't know, but we get used to this. In any intensive care, if the heart gets affected, the kidney will be affected. Liver, yes, we have a deranged liver enzyme, high bilirubin, which even may go more with the severity. Brain gets affected. We have a reported case about arterial stroke during the era of COVID. So, and this will raise whether we use anticoagulant or no. I put the flag here, Saudi Arabia, because apparently when I ask every single person I know from cardiology, rheumatology, PICU, we don't see these cases in our area. Why? The reason is not known. I hope that we are a bit lucky. But does it have to do with the virulence of the organism? Does it have to do with the genetic makeup? So it's not clear. So mainly we are talking about this phase, the hot inflammatory response phase, where we have a very sick children, but they are rarely presenting to us, and what to do with them. When I reflect on our management for a similar cases, I just remember two patients. One of them, it's almost 3-4 months prior to COVID. One of them is a Kawasaki's disease shock syndrome, and he was well managed and was transferred healthy, at least safe, to the general pediatric. And the other case was again a child who got an arterial CNS thrombosis. And this thrombosis was again very new to us. We are not expert in the stroke like adult, but we collected the opinion and we managed him, and he was transferred from our unit alive. So what I wanted to say, in the literature, you will see many things, a lot of publication. But when I go as a pediatrician and as a pediatric intensivist, I found myself that it's not a totally new illness to us. Because again, Kawasaki disease shock syndrome, we don't know what is the trigger outside the COVID, and we are not sure whether COVID-19 or the virus in this season is the provocative factor behind the Kawasaki disease. So you will see in the publication, Recognition of Kawasaki Disease Shock Syndrome. This was published 2009. So we are really equipped with this manifestation and also with the knowledge how to treat this disease. ECMO and COVID, again, this is and the lymphopenia. This is under very debate, and but we know our situation and whether we can put patient on ECMO institution per institution outside COVID or in the era of COVID. So, and you will find a lot of publication. What do we need to do with these rarely presenting sick children? I think the most important thing is a multidisciplinary meeting to share opinions. And again, I repeat myself, opinions. None of us is expert. So we will have all these umbrellas, cardiology colleagues, rheumatology colleagues, hematology, immunology, ID, nephro, neuro, even the clinical pharmacist, and us intensivists, just to sit around the table and discuss what is the best behind evidence and what is the best for the affected child, and then come with a plan like this, a decision plan which can be a base from every opinion. Recently, as Dr. Yasser mentioned, on 27th of April, a plethora of cases in UK and then in New York started to appear in the media, in the conferences, in the literature about the Kawasaki disease shock syndrome. And that was a very important date, 2nd of May. There was a webinar which really explained all the cases, the clinical cases, and the severity of the cases and how to manage them. Again, they have the same question mark about which is the best management, and but at the end of the day, all the children in any pediatric intensive care unit will be supported, and the organs will be supported as usual. This just to confirm that it appears also in New York, and 4th of May, COVID-19 associated Kawasaki disease, shock syndrome is there, and we need to be aware of them. When we come to the novel and investigational therapies, adult literature and the adults are really busy with the critically ill adult, and also with a lot of trials. So you will hear about the antiviral therapy, different names. One of them is hydroxychloroquine with or without azithromycin, chloroquine, and recently people are shying from this medication treating COVID-19 in adults, and the main talk is about the remdesivir, but still nothing is very promising. Again, remember that we are dealing with the children, and adult is not a small child. Empiric anticoagulation and thrombosis, again, in children, it's not an easy decision. It has to do case by case. And again, I don't think this will differ with the COVID situation. Steroid, yes and no, immunotherapy, and I think the main opinion would be between the rheumatology, immunology, and cardiology if we reach the stage of having a sick child with Kawasaki disease shock syndrome. So, to conclude, vulnerability is the constant context during pandemic. This should be addressed by public health and Ministry of Health everywhere. Justice and non-maleficence comes first. Children may die from non-COVID-19 disease. Children may miss their vaccines and create another pandemic. So thank you very much for our home health care, who will reach our children at home to vaccinate them. Children with severe COVID-19 are infrequent. Their standard of care depends on the circumstances, and it's case by case and with a scientific opinion. There is no expert on the field. Documentation of multidisciplinary decision is mandatory and useful in managing future cases. Uncertainty should not contaminate the process of critical thinking and giving opinion. So what we need to do, we have to have never-ending learning process. Prepare yourself for another talk from the same group in Europe and USA on 23rd of May, and they are preparing themselves to update us. Stay home and flatten the curve, and remember, cure is almost from Allah subhanahu wa ta'ala. By this, I'm concluding my talk, and I'd like to present the next speaker, Dr. Ali Shihri, BICU Division Head, and he will talk about the strategic planning as a preparedness in COVID. Thank you.
Dr. Ali?
Yes. Can you see my presentation?
Yes.
Is it moving?
Yes.
Okay, thank you. Good evening, everybody. I'm so privileged to be today. Thanks for my colleague, Dr. Yasser, Dr. Hamza, Dr. Hala, to introduce the clinical presentation and epidemiology for you. My part, I will talk about pediatric intensive care unit strategic preparedness for COVID-19. So during the next few minutes, I will try to cover the pediatric intensive care unit operational planning during COVID-19 pandemic. We will try to cover some measures that has to be taken at the level of the pediatric intensive care unit to protect our frontline staff and healthcare worker. And I will try to cover some important clinical guidelines that we recommend to have them early in the pandemic to streamline among the healthcare worker in the ICU. So as my colleague presented earlier, the rate of COVID-19 is very low in pediatric populations. Our experience regarding how to manage and how to prepare for this pandemic, it is a cumulative experience, came from the previous corona and SARS infection. Then over the last 5 months during the COVID pandemic, from many reports coming from CDC, from experience from came from World Health Organization, other country that has a pandemic. Most of the preparedness literature and guideline came from adult, and I have to disclose this. But I think we have a lot of things that we could implement it to our pediatric populations. Few narrative review from different country also about pediatrics, and I'll try to get all this together and to put all the information to come with the relative preparedness plan for PICU during this pandemic. So early on the pandemic, I think now we are almost 3 months from receiving the first case in Saudi Arabia, and I think many hospitals may encounter one or few cases in the pediatric ICU. Some hospitals not. We have different structure from healthcare services. We have a children hospital with independent large PICU, and we have another institute who may have the ICU. It is just part from adult ICU in the small caliber. However, the leadership in the pediatric intensive care unit should work hand by hand with the other higher management to build a plan early in the pandemic, and this plan should anticipate any overwhelming outbreak at any time. We know the rate is low, but the thing may go wrong, especially with the losing of the lockdown process, and even there is some concern that the disease may change the severity in the future and it may become more severe in the children. So I think for the next few months we have to be get prepared all the time, and we have a plan on the table what we should do for the next few months. The plan should aim to assist the local health resources regularly. So at early on the pandemic and during the pandemic, also the director and medical director at the level of the ICU should assess early their current situation at the level of the resources, manpower and supply, and also to look what is the projected needs if anything went wrong or if there is any sudden increase in the number of the PICU. So also you have to adjust this by knowing of your healthcare system, what is the level that you have and what is the resource you have. So no hospital like others. Also this planning early, it should also aim to protect our frontline staff and reduce the transmission of the infection, and also to achieve the ultimate goal of the critical care management to provide an excellent critical care delivery that minimize the mortality for both population, COVID and non-COVID. As Dr. Hala mentioned, we should not forget that we are managing a non-COVID patient, and maybe at current situation there still have high proportion compared with the COVID patients in our area. So our plan for preparedness should include what we're supposed to do for them as well. Your plan has to be flexible and resilient to accommodate any changes in the recommendation. We know during the pandemic, the recommendation has been changed at the level of the country, MOH, or at the level of the institute. So it has to be resilient and able to accommodate all these changes. So what you need to start with, you need to start, as I said, to assess your local healthcare resources. understand your hospital. At the level of the ICU, you need to identify our current situation of the ventilators and also the alternative ventilator that maybe you need to use it in the future, as the chronic ventilator, transport ventilator, anesthesia ventilator, or neonatal ventilator. You need to estimate your current status of non-invasive ventilator support, also a consumable, including the face mask, ambu bagging, and respiratory support. Also, you need to estimate your current status on from the ICU beds, how many beds you have, and also how many alternative beds you may have either outside the ICU or in other area in the hospital, including the ward. So I think this is one important step. You need to have a qualitative assessment, or sorry, you have to need to quantitative. So you need to know how much you have at the present, and you build on it your plan. One of the important things, which is the key of success to survive the pandemic, is maintain good communication through whole pandemic and outbreak. So at the level of the hospital management, I think we have to an well-established command team composed from the leaders, from the higher management, and it has a good communication tool with the Ministry of Health and Higher Healthcare Management, like Ministry of Health and also Saudi CDC. It should be able to deliver all the information to the frontline staff through appropriate communication tools. So any changes in the infection control process, any change in the definition of the disease status, or any new diagnosed case that could have impact in the future in your practice in the PICU should be continuously on daily basis communicated from the higher management into the frontline staff. In our institute, we set early on the pandemic, we could generate this manual, which is the hospital preparedness and management of pediatric population during COVID-19 outbreak. It is facilitate and stream the work between the PICU and all other pediatric departments, including emergency room and operating room, and also identifying the backup plan and the surgery plan. Many slides on communication, because I think this is the key of success. So at level of the ICU, you need to maintain a good, accessible, updated healthcare information system. Commonly, we use email or computer on the PICU. That should have a well updated WHO, MOH, CDC, or any interim guideline from infection control point of view in real time. It's important to the leader to identify a good distant communication tool with the all PICU staff on the level of the nursing, respiratory service, and all other allied service. And commonly we use now a video conference, so we use it in demand and also to communicate frequently with our team. Also, it's important to the higher level management at the level of the ICU to implement a program for employee and for emotional and psychological support. We know our staff in the ICU at extreme risk to acquiring infection. They have a lot of stress. So we have a good communication tool with them. Commonly, we use a hotline that our staff could access it to present any symptom or to present any concern regarding the COVID-19. At the level of the division unit, there must be a good guideline. We recommend every unit, based on understanding the situation in the unit, to create and educate all PICU frontline healthcare worker on a new PICU operational and clinical guideline, which is relevant to COVID-19. Identify the minor difference that has been presented with my colleague earlier. Already that we have in our unit a clear guideline for PPE and working flow, transport policy, intubation, and CPR. We were successful to have all these guidelines written in the guideline and disseminated, and we educate our staff on it, so we'll not be surprised when we face the first case of the COVID-19. Important education tool, simulation. There is a challenge with simulation because exposure to wasting of the PPE, but what we are using, we use a videotaping. We recommend it, so you can use it once, then keep it in an accessible area to all the staff to look for the PPE example, donning, doffing, so they could master the skills. It's important also in our guidelines, as I mentioned, due to the nature of the ICU diseases, most of our patients, they have some kind of aerosol generating procedures. So it is clearly you have to actually to clearly clarify this procedure to your staff and make sure they have a full PPE, negative pressure room or HEPA filter equipped room and airborne isolation when they exposed to this. We recommend all ICU, if they could have all single rooms and negative pressure room is possible, because at one time our patient will have one of these procedures. So according to WHO, any procedure like intubation, extubation, bag mask ventilation, high flow nasal cannula, invasive ventilation, high frequency ventilation, nebulization and suction, or cardiopulmonary resuscitation or bronchoscopy should be done, as I said, negative pressure room or HEPA filter equipped room with airborne precaution. Our guideline also, it is clearly clarified the endotracheal intubation. Dr. Hamza, he explained the procedure itself. However, from logistic and from operational point of view, all you need to ensure your staff as protected from acquiring the aerosol which can result in the infections. So the process it should be cleared as well in the guideline, and your staff should have simulation and trained on it. So we clarify, in addition to the procedures, we identify which the allocation of the team who involved into the intubation. We recommend the minimum number of staff which is led by the most expert physician for intubation. We were successful to minimize it into 3 staff. We identify where they should stay, so 3 of them should be inside the room or in the intubation field, and the other should be all outside the room to minimize the infections. Also, having intubation a checklist also has been recommended, and also we has implemented this. So we clearly state what is the requirement for the checklist for all COVID patients, which should be prepared early. We know those patients, as has been also presented, they recommend intubation early, so they may have low reserve and rapid deterioration. So the checklist already in place for all those patients. Another relevant PICU specific guideline is the cardiopulmonary resuscitation. For the same concern, try to make your staff safe during this procedure. So based on our recommendation and American Heart Association, so we identify which team should be inside the room, also led by the most experienced staff, and we identify the role and responsibility for every single members, and who should stay outside the room. We recommend, as I said, it should be full PPE, limited code team members, intubating early the patient during the code. Also, we identify where you should keep the crash cart. So crash cart should be stay outside the room, and the defibrillator inside the room to avoid any confusion during the catastrophe. And also we identify also the guideline, how would you do the disinfected to this equipment, and how did you dispose the material inside the room before leaving the room after the code. This is the graph that you can see it in any area also in our unit, so to be clear to our staff. Important thing as well, in addition to the communication, is the infection control measures. Our guideline should be clearly aimed to rapid identification, isolation, and testing, which is present in I think in all hospital. Every single staff in ICU should know how and when to minimize to use the PPE to minimize the waste. We recommend, as based on WHO recommendation, all patients will be on the contact and droplet isolation, except when you providing high aerosol generation procedure, which is most of our situation will need, so they have to be in airborne isolation. Our institute and unit should be ready to disseminate a reuse guideline during the pandemic, and we recommend using a single-use supply or dispensable supply for specifically for COVID patients. And to minimize, important step also in ICU, we need to minimize the direct contact and routine transport. So do not do any transport unless really necessary, and to avoid the routine investigation, and try to use more bedside evaluation, for example, bedside ultrasound. Infrastructure should be assessed also early in the process. So you need to estimate, as I said, in quantitative manner, how many single room you have in the PICU, how many negative pressure room, the need and requirement for HEPA filter if you have a regular ventilated room. And we recommend during the crisis to have a designated COVID PICU unit, so you can admit the patient who are suspected or positive to that unit, and you minimize the cross infection. Based on based on the WHO, there is a recommendation that the recommendation is clear to have a patient in the negative pressure room during oralized procedures, and patient he may stay if the negative pressure room is not available, so you can put him in the normal pressure room with HEPA filter. If it is not available, also because you know the resources is different, you need to identify some area that you can cohort the patient with maintaining a good distance between the patient. PICU capacity, you need to look at it also early, and in particular planning for surge response. What we mean by surge response, when we have many cases happened all suddenly to overwhelm your system. And I agree to my colleague that the rate is low and we may not see this in pediatric. However, you need to get prepared. So you need to estimate your current and projected staff, as I said earlier. You need to establish a hospital escalating model, including outside transfer. This is very applicable for centralized regional healthcare services. When there's a multiple hospital with joint information, and they can transfer the patient between them, so they have to identify which patient can be transferred, whether COVID or non-COVID, when and how. Do you need to do phase increase in the bed capacity? You have to plan it earlier. How would you increase the bed capacity of the PICU? And we recommend, if you have single room outside the PICU, so you can identify it either in the general pediatric ward or high dependent unit, or even in the cardiac ICU, which is available. So pediatric cardiac ICUs, you need to identify this area. In our institute, we could manage to open a unit with 20 bed for a COVID patient, and we could, if any surge happened, we managed to open a 12 bed in the ward, which is ready to receive a patient. You need to identify the suitability of the room for those they will receive the patient, and also if that's exceeding the capacity, we decide to move the patient to the pediatric cardiac ICU. You need to cancel all elective procedures, mainly post-op, and you need to minimize the waste during the pandemic. As I said earlier, limit the procedure and limit the personnel as well, and personal contact. So avoid to see the patient unnecessarily. So minimize the patient's contact is important. In addition, consulting the expert, as my colleague also presented, is important to avoid the waste of the medication and the waste of the PEE, especially when you think about using the therapeutic research therapy or other antibiotics. So there is a talk about using a multiple patients per ventilator. The final word, it is not recommended, and the recommendation is to use a home vent, chronic vent, portable ventilator, anesthesia ventilator, and this has been not recommended by many society, including the Saudi Critical Care Society. PICU staffing, important thing to look as well as when you are preparing. So you have to plan, you have to be clear plan from where you will get other extra PICU staff, especially when you have infected staff in your unit and you are not capable to run the unit in face of the surge. So and you may think about recruiting from other unit, from other area, from ER or from general pediatric, the staff who is expert to deal with moderately sick patient. However, you need to estimate this early in the process. You need to save the staff. You have to provide to minimize the infection. So you need to minimize unprotected exposure in your unit. So you need to make sure availability of the PPE. You need to ensure it is implemented well. It's not overused or wasted. You need to make sure the people know when or how to take it. Many reports came that the infection to the healthcare worker acquired during the donning and doffing if it is not done properly. We recommend also a designated team to cover a COVID unit, as I said, or COVID patient if the COVID unit, if it is not available. And also we recommend to minimize the staff who is working to 50% or less if you can run your clinical management. A person who's as needed, he can stay away from the unit, so you can segregate the work between teams. So if somebody is infected, you need to call the others. We recommend highly to use a communication tool between all of them, commonly the teleconference as well, to avoid the contact. Triaging, I think it is common, you see this in adults. It is hardly to found it in the pediatric literature, and this is when you think about PICU triaging, you think it's usually the time that you need to think about it when your search plan already overwhelmed. So you need to prioritize which patient you need to give him the full support, or the other patient you may withdraw the support for him. This is the difficult ethical decision in the pediatric. I don't think there is any specific guideline has been made for pediatric. However, you may find some recommendation in adults. If you think you could use it, it's at any situation, so it has to be well supported by the local health system and the legislation system in your area or your country. Important thing is the parent. We obligated to provide family-centered care, and the overall, most of the ICUs now, they restrict the visit, but however we cannot restrict it 100%, and we don't recommend this. We recommend you allow some family to for exceptional situation to visit their child. You need to identify the criteria. We recommend sick child, or to provide psychological support for end life support, and also to offer the family other alternative communication tool. What we are using in our unit, we use a virtual visit using iPad. And also we introduced recently the daily phone communication tool. We did not know the impact of this and the emotional distress on the family, but we may look at it later. But I think it is important to deliver this, and as the family center concept, even during the crisis. However, it has to be for exceptional situation. What's important for you, that all parents should also follow the PPE rules and ensure that has been clearly stated for them. So I would conclude my presentation by delivering some messages that the reduced transmission is the best tool to control disease. Reduce communication with frontline healthcare worker is the key for success. I will repeat it: communication, communication, and communication. You need to assess and plan the healthcare resources regularly, and you need to be very, very careful and aiming to protect your healthcare worker and support them. Thank you very much.
Now, yeah. Are you all ready for the question and answer sessions?
Okay.
Yes.
Okay.
I will start. Can you hear me? We have welcome back again, everybody. First question from Tariq Ali, and he asked any written guidance for treatment of COVID-19 in children. Actually, up to the moment, apart from the local guidelines, institutional guidelines, every hospital, they generated their own guidelines, as we did in our hospital cache. The only published guidelines is from the Pediatric Mechanical Ventilation Consensus Conference, which is the respiratory failure part section of the European Society for Pediatric and Neonatal Intensive Care. This is the only international published guidelines. It's free, actually, and it's accessible over the net. I found it very useful. I hope that was helpful for you, Tariq. There's another question from Ala, or Ala, I don't know, actually. For intubation and mechanical ventilation, we need full PPEs and negative room. My question is, what type of mask, surgical mask or N95 mask? Of course, the intubation, it is an aerosol generating procedure with close contact with a severely and critically ill child. So you need to wear the most protective PPEs. So it should be N95 with face shield or goggles. If you have, of course, water-resistant blue gown. So full protection in this procedure, including N95 mask. There's a third question from Dr. Ahmed Al-Ahmadati. Does your protocol include routine use of hydroxychloroquine? Actually, we provided our guidelines, local guidelines in CASH in the beginning of the crisis, and yes, it does include, of course, for the severe COVID-19 critically ill children, yes, it includes, but again, it includes something else. Our guidelines include mandatory consultation with our colleagues in the ID team. So before starting the hydroxychloroquine, benefit versus risk should be assessed and it should be approved by the ID. But yes, it's included in the protocol till now. It might be changed, you know, the data is changing. This is for me. There is another question from Anonymous. I don't know. What treatment you are using at the moment? As I said, actually, our local guidelines in Children's Hospital, King Abdullah Special Children's Hospital, it includes the antibacterial when it is indicated, hydroxychloroquine. Antiviral, it is not included in the local guidelines, our hospital guidelines like leponivir or the combination. But again, it is recommended by our ID team. We will utilize that medication. I think Ministry of Health also, it has a full detailed guidelines regarding what antiviral, antimicrobial to be used in this treatment. Thank you.
I just read a question from Dr. Abdullah Al-Qubaishi, our colleague in Jeddah. Any local experience in PICU? It disappeared.
No, it went to published.
Published, okay. So, any local experience about pediatric COVID-19 in Riyadh required PICU? As far as our unit and when we communicate with our colleagues, whoever majority of the cases comes as a suspected COVID, and their main symptoms is GI, some fever, but at the end of the day, they are proved to be negative, and if any positive, it will be very mild, and if any death, it will be from the comorbidity. So still, we don't see the severe cases in PICU in Riyadh. Apparently, the same in Medina, Jeddah. You are more aware than me. Another question, what treatment you are using at the moment? To be frank with you, there is no treatment, no vaccination. So nobody can say this works, this does not work. Even the adults are shying from the hydroxychloroquine. So I cannot say we will continue putting hydroxychloroquine in the guideline. This is a dynamic process. Wait for the 23rd of May and attend the webinar and see. I'm sure they will have more update, especially that they see many children in UK, Boston, New York, and they keep updating us, and they are involving these children in RCT. Any other questions?
There is one question from Muhammad Barashid. Can we depend on non-invasive positive pressure ventilation in pediatric population? Actually, using the respiratory support in COVID-19, it doesn't differ from non-COVID patients. So if you have a patient with respiratory failure who requires non-invasive positive pressure ventilation, of course you can use it actually. But as we said, It's an aerosol generating procedure. You need to be careful. You need to protect yourself, protect your team. And the other point, don't delay the intubation. So your patient should be monitored closely during the coming 60 to 90 minutes. If there is no improvement or deterioration or whatever, you need to utilize the intubation as soon as you can. But of course, yes, we can use it whenever it is indicated. Thank you.
There is a question from Yasser. Refractory hypoxia with no apparent distress in adult is well-recognized phenomena. How about pediatrics? We don't see this till now. We don't see it, and if anything, it will be between acute inflamed abdomen and cardiac. That's per the UK and the New York reports. We did not see it in our country. What is the scoring system in children? Because GI symptoms more than respiratory from Samah, it remains the same. The scoring has to do from which area and what are the presenting features. It doesn't change. We follow the agreed on scoring system in the kingdom.
So thank you all speakers. It was a very wonderful evening session. I hope all the participants have enjoyed it. And now I think we are at the end of the session and we need to end the session. If there are no more questions to answer.
Just I'd like to have some evaluation about this webinar, so we will, when we do another one, we will be near perfect.
Yeah, that'll sure. We will share from the survey, inshallah. Thank you, Dr. Hala. Thank you, Dr. Yasser, Dr. Hamza, and Dr. Ali Al-Shari. Thank you, Engineer Altaf, for a wonderful technical support. Thank you.
Thank you very much.
Thank you for all of you.